Good morning, everybody. In conjunction with World Heart Day this year, we were going to talk a little bit about heart surgery. I am Dr. Eng, cardiothoracic surgeon here at the KPJ Damansara Specialist Hospital. So today we're going to talk about minimally invasive heart surgery. And I believe that this is probably the safest way to treat heart disease. Now, when people come to hospitals and they advise to have treatment, surgery, say, heart surgery especially, they are usually a bit worried about coming for this kind of surgery because they think it is massive. Right? So they are worried about the risks associated with the surgery. In terms of heart surgery, the risk would include having a stroke during or afterwards, and also the risk of death following the surgery. In addition, most people think that heart surgery is massive, so we need to make big cuts on the chest and the legs and so on. So they need to stay quite a long time in the hospital, including in the intensive care unit. So they may need to spend maybe a week or more in the hospital, and the recovery afterwards would take maybe another month or so, sometimes even longer. So these are the conventional worries that most people have when they have to think about undergoing heart surgery. And as you know, that coronary artery bypass grafting is the commonest operations performed around the world. And in every year, we have more than 1 million operations. Now, we can overcome all these worries about the heart surgery, of the risk of the surgery and so on, with a new approach to heart surgery we call minimally invasive heart surgery. Right? Minimally invasive means that we do not make big cuts like we conventionally do. In addition, there's a big change from the previous surgery in that we do not have to stop the heart. Right? So this is the concept of minimally invasive coronary artery bypass surgery. When this thing first started, we were doing just single bypass graft to a small incision on the left chest. But with refinement of surgical techniques and equipment, we are now able to do multiple bypasses. So in this particular procedure called minimally invasive coronary artery bypass grafting, we just make a small incision, maybe 5 to 6 centimeters long, on the left side of the chest. That's all. We're not opening the sternum. So through these small incisions, we can harvest the internal mammary artery. This is the artery that runs inside the chest. There are two of them, one on the left and one on the right. Right? So when we were doing what we call mid-cap, we were using just the left internal mammary artery. But with this new concept, through this small cut on the left side of the chest, we can not only harvest the left internal mammary artery, but also the right internal mammary artery without opening the right side of the chest or central median sternotomy. So all these operations are done, the procedures are done through this small incision on the left side of the chest. So we will harvest both the internal mammary arteries on the left and the right, and then we would disconnect the right internal thoracic internal mammary artery, and then we will connect it to the left internal mammary artery in a special fashion called a wire graft configuration. Right? So once we've done this, we can then use the two internal mammary arteries to bypass whichever coronary artery the grafts that we need to do. Right? So conventionally, we still use the left internal mammary artery on the front of the heart. This is a so-called gold standard of coronary artery bypass grafting. We can then use the right internal mammary artery, which has been connected to the left internal mammary artery, to bypass the rest of the heart, the back of the heart, to the right side. And in most patients, the length is more than adequate to cover the whole surface of the back to the right side of the heart. So we can do multiple bypasses through this procedure, through this technique, using both internal mammary arteries. So the major difference is that we are not opening the chest in the usual way, so to make it more comfortable for the patient and the healing would be easier. And secondly, because we're using both internal mammary arteries and they are enough to do as many as 3, 4, 5 bypasses, we do not need to cut the leg to harvest leg vein or the arm to harvest the radial artery. So which means that the recovery would be a lot faster for the patients, and most patients then would be able to walk around, say, the day following the surgery. Now, in this procedure, is a variation of what we call the off-pump beating heart surgery. Right? So that means we do not have to stop the heart at all. The heart would still be beating. We use a special instrument called the stabilizer to stabilize a little part of the heart where we want to do the connect the coronary artery bypass graft without stopping the whole heart. Right? So in this situation, we do not have to cannulate the heart either directly or through other areas. Some people use what we call peripheral bypass, where they cannulate the femoral artery and vein. But we do not have to do that. We use beating up off-pump surgery. So the combination of minimal incision, a small incision on the chest, and beating heart surgery. So eliminating having to stop the heart using the heart lung machine and so on and so forth. So this kind of surgery can result in much speedier recovery. So maybe just 1 day stay in the intensive care unit and maybe 3 or 4 days stay overall in the hospital. Following this, if necessary, patient can recover well enough to go back to work if they want to within a week. And that's been the experience of some centers that have been doing this thing for a long time. So the pain will be less, the overall recovery will be faster, so this then would be much more preferable to patients. Now, when we compare this minimally invasive coronary artery bypass grafting, as I described, with percutaneous coronary intervention, that is angioplasty and stenting, there are two major advantages. The overall risk of the operation, as I described earlier, is much reduced. The incidence of stroke is less than 1%. Now, remember that I said that we do not have to cannulate the aorta. We do not have to stop the heart. And because we are using both internal mammary arteries, we do not have to connect the graft to the aorta. That means that we do not have to touch the aorta at all. We call this the ep aorta, or no touch aortic procedure, right? So, because of that, the risk of stroke, and most of the time stroke occurs because of embolization, right? That is small material that's been thrown off from the aorta, which then comes and block the circulation to the brain, right? As a result, people get stroke. Now, because we are not manipulating the aorta whatsoever, the risk of stroke is much reduced, and there are a series of reports saying that the risk of stroke is 0, or less than 1% anyway. Now, when we compare the percutaneous coronary intervention, that is angioplasty and stenting, there is a big difference here, because in order to get to the coronary arteries from inside, that is, the cardiologist will need to pass guide wires and catheters and stents and balloons and special instruments, rotablators and so on. They all have to pass through the aorta and then only get into the coronary arteries. These are very small arteries, right? So this internal manipulation of the aorta can cause dislodging of what we call atherosclerotic material from within the aorta. So that risk is the same compared to conventional heart surgery, right? Where we have to cannulate the aorta and put top end and put clamps on the aorta and so on. But with the minimally invasive procedure that I described earlier, we do not have to touch the aorta at all. We do not have to put the patient to this kind of risk. Unfortunately, this is not possible for percutaneous coronary intervention because everything has to pass through the aorta in order to get into the coronary artery. Now, studies have shown that even though the risk of stroke from percutaneous coronary intervention is low, less than 1%, but if you use a very sensitive technique to look at the brain using magnetic resonance imaging to study the brain following just routine cardiac catheterization rather than intervention, right? The incidence of what we call silent stroke, that is, patients sustain damage to the brain, as we can see from the MRI, but they are not so bad that patient actually becomes symptomatic, or so patient develop weakness of the arms and legs and so on. But we can detect the damage, injury to the brain from the percutaneous coronary intervention. Now, it is estimated that the risk could be as high as 15 to 32%. And in patients who are ill and whose aorta are badly calcified and damaged, the risk could be more than 50%. So, in this consideration, I think that the surgery procedure or minimally invasive coronary artery bypass grafting, as I described, without heart lung machine, without doing opening the sternum and so on, is actually safer compared to percutaneous coronary intervention, right? Now, the other major advantage is the long-term result of the treatment. All along, patients who undergo percutaneous coronary intervention, that is angioplasty and stenting, have higher incidence of recurrent disease, that is, the developed blockage of the artery again and again. Now, you may be advised that, well, that is not a major problem, then because we can do it again, right? Because we know if blocked, we can open it again. Unfortunately, sometimes things can happen very, very suddenly, and there's no chance for patient to get to the hospital, let alone to get into the cath lab. So because of that, even the medium term, 3 or 4 years after the procedure, we can see a difference already, not just in terms of chest pain and symptoms and so on, but in terms of death, mortality. There is a survival advantage if we compare these two modalities of treatment, that is percutaneous coronary intervention and bypass operation. Right? Even if we use the conventional way of doing it in the older days, right? But with this refinement of minimally invasive cardiac surgery, where we do not open the chest, open the sternum, we do not touch the aorta, we do not use the heart lung machine, the risk is much, much reduced. So it is much preferable compared to percutaneous coronary intervention. And it is my belief, my conclusion is that this is actually the safest way we can use to treat patients with coronary artery disease. Now, so this is as far as treating the coronary artery disease is concerned.